Welcome, everyone. Good morning. As people are joining, please put your names in the chat. Introduce yourself with what hospital you're from, what title you have, any pronouns you prefer. We would love to greet each other. And I want to introduce myself quickly. I'm Dr. Jennifer Zhan. I am a clinical implementation leader with the EDSP program. Welcome to today's Test to Treat webinar, where we will talk about treatment for syphilis, HIV, and hepatitis C. Bridge is a part of the Public Health Institute, and we are so proud to administer the EDSP program with our colleagues from the California Department of Public Health for your teams across California. And our partners at CDPH provide subject matter expertise to support technical assistance and evaluation of EDSP. I'm Dr. Jennifer Zhan. Want to introduce myself real quick. I am an emergency medicine physician in LA. I also work as a clinical implementation leader for the Bridge program. I worked as a implementation leader for the California Bridge program for many years before joining this team. I have worked with many of your hospitals on our the California Bridge program, and I'm excited to see you guys here as well. I want to introduce Dr. Kathleen Jacobson, who will present the webinar today. She is incredibly brilliant. I'm honored to work with her. Let's just go over the agenda and then we'll pass it over. Here's our agenda today. We are going to talk about syphilis, HIV, and hepatitis C test to treat workflows. Essentially talk about empiric syphilis, HIV, and hepatitis C treatment. This is what a lot of you guys have been waiting for. We've put a ton of effort into these pathways, and we're so excited to share it with you. And we'll also talk about the syphilis treatment and Bicillin shortage update, and then do a little Q&A and wrap up at the end. So with that, Dr. Kathleen Jacobson will take over.
Yeah, and I'm just going to start by letting folks know that there's a strong possibility that we will not get through all of today's algorithms. And if we don't complete them today, if it just takes a few minutes overtime, we'll go a few minutes overtime. If it looks like we have another 15 or 20 minutes, then we'll complete these tomorrow at the community of practice. And we plan to record all of it. So meaning all of the discussion of the algorithms. So if for any reason you miss any portion of it, you'll be able to capture those via video. So first, to say that these algorithms are a stepwise approach to treatment for either syphilis, HIV, or Hep C in the emergency departments. And I'll let you know up front that these algorithms are intentionally organized to identify key findings that may impact syphilis, HIV, or Hep C treatment. That is the purpose of these algorithms. Each algorithm is focused on a given infection and key symptoms, again, that impact the treatment for that particular infection. And most importantly, these algorithms are not meant to be a comprehensive workup for individuals in the emergency department with these symptoms, but rather just to help you identify whether or not you can begin treatment for syphilis, HIV, or Hep C. We fully recognize that there are other common illnesses and infections that may cause similar symptoms, and patients should be worked up and treated accordingly for other diseases as you believe is clinically indicated. So really the focus of these are, should you begin treatment? And if so, what treatment should you begin for syphilis, HIV, or Hep C? Next slide. So with that, we're going to switch over to the syphilis test to treat algorithms. And I'm going to share that from my screen here. And let me know if you're able to see this okay. I need to close down a few things. Okay. All right, so for syphilis, beginning with a positive test, and we recognize that each emergency department is going to have a different test, or may have a different test. You may have a TPA, you may have an RPR, or you may have a point of care test that comes back positive. Doesn't really matter which initial test comes back positive. If you have a positive test, any one of those, really your first question is the patient symptomatic? And that's really what you want to address with that patient. And we want you to all become familiar with these symptoms because they are quite subtle. And if you don't ask for them, patients are unlikely to complain of them, but they're really critical for identifying an individual with otic, ocular, or neurosyphilis. And so I'm going to go through those symptoms and just talk through them for a minute. So for otic syphilis, decreased hearing can often be one of the first signs, not just of otic syphilis, but actually of neurologic syphilis. So asking patients, have they noticed any decline in hearing in the last month or two, is really critical to help you identify if this person might have neurosyphilis. And if it's in isolation, it would be otic syphilis. Also, although I'll say certainly less commonly, tinnitus or vertigo can also be associated with their otic syphilis symptoms. Ocular, one of the most common presentations that often gets missed for ocular syphilis is simply a red eye or conjunctivitis. Patients often get sent home and told they don't have syphilis, when in fact they not only have syphilis, but they have ocular syphilis and need admission to the hospital for IV treatment. Additionally, they can have either blurry vision as part of that ocular syphilis, and this can often be unilateral, but can progress to bilateral. But more commonly, it's unilateral. The double vision is actually a sign of neurologic involvement because it means it's involved the cranial nerve 6. The ocular syphilis can progress to vision loss. So first blurry or decreased vision, but it can progress to complete blindness and vision loss. And that does not come back after treatment. And then most of you remember from medical school, the Argyll-Robertson pupil, where the pupil accommodates but does not react to light. Again, that's a sign that you have neurologic syphilis, because even though you're seeing it in the eyes, the issue is in the MLF of the neurologic symptom or system. Then next, moving on to the more pure neurologic symptoms: headache, confusion, ataxia, and the ataxia can be quite subtle, weakness or numbness, any neuropathy, and then decreased patellar or Achilles reflexes. So all of those are for otic, ocular, and neurologic symptoms. These are all reasons why patients need to be admitted for their syphilis and be placed on IV treatment for 10 to 14 days. So asking these questions up front, which often don't get asked, but asking them up front, if patients have them, you're committed to admit that individual for otic, ocular, or neurologic syphilis treatment, which again is 10 to 14 days of IV treatment. So the other symptom to ask is cardiac symptoms. So do they have any chest pain? We do see more cardiac syphilis these days, and often it can just present as any cardiac or chest pain or discomfort. And so if it's yes to any of these in the red, then you move over to the workup. So if you have neurologic symptoms, or you have neurologic plus otic or ocular symptoms, the patient needs a lumbar puncture. If you have purely otic symptoms with no other neurologic finds, or purely ocular symptoms with no other neurologic findings, you don't have to do the LP, but you do have to admit them to the hospital. And if they have any neurologic symptoms, and again, just a reminder, double vision or Argyll-Robertson would put you into neurologic. So those individuals would need a CT of the head and a lumbar puncture with a CSF VDRL, cell count, glucose, and protein. And the cell count, glucose, and protein are really important because only about 50% of the time is a VDRL positive in an individual who actually has neurosyphilis. So we rely heavily on the cell count and protein to really help us make that diagnosis and then follow that person clinically in the future. Again, if just otic or just ocular symptoms, no LP is indicated. And then if they have cardiac symptoms, they need a CT or an MRI of the chest with contrast to look for aortitis. And then, as I mentioned, if you confirm they have isolated ocular or isolated otic or any combination of these, that individual gets admitted to the hospital and needs to be given IV aqueous crystalline penicillin G, 18 to 24 million units per day, administered as 3 to 4 million units IV every 4 hours for 10 to 14 days. If they have isolated cardiovascular syphilis, so they just have chest pain, they have no other neuro-otic or ocular symptoms, then that individual can actually just be treated with 3 IM doses of benzathine penicillin G, 2.4 million units IM weekly times 3 weeks. I know that was a lot. I don't know if there's questions in the chat, or if anybody has any questions before I move on. And I'll let somebody else monitor the chat for me.
Of course, no questions in the chat just yet, Dr. Jacobson.
Okay, great. Then we're going to come back to the symptoms. So we went through the ocular, otic, and neuro symptoms as well as cardiac. Then to just walk through primary and secondary syphilis, which I know you all know, but there are unique presentations lately of primary syphilis that would not follow the classic textbook findings. So historically, we think of primary syphilis as having a single painless ulcer or chancre. However, more and more during this current outbreak of syphilis that we're having, individuals will have multiple, often painful ulcers that look very much like herpes. And so these patients often get misdiagnosed as herpes, and they never get tested or treated for syphilis. So if you're looking at a patient and you think you're looking at at herpes, also test them for syphilis and really truly consider empirically treating them for syphilis, because the two can look exactly like each other, which is probably part of the reason that this current outbreak of syphilis has sometimes been missed, because folks think they're treating herpes, and patients of course get better because the chancres get better on their own. Secondary syphilis, all of you know about the macular-papular rash, which I will say does not always involve the palms and soles, and can be very subtle in presentation. In fact, in people who tend to be have either black or brown skin, it can, particularly on the feet, can often just look like scarring on the feet if it does involve the palms and soles. So it can be misleading. And we have a few images I'll show you in a minute. But other findings of secondary syphilis are fevers, chills, and just diffuse lymphadenopathy, because by the time you have secondary syphilis, the disease has disseminated to the rest of the body. They can have mucus pouches. They can also have patchy alopecia or condyloma lata. So I'm going to show you these images up here. Let me know if you can see them. So here's an example of multiple syphilitic ulcers. And this one I would say is more obvious than others because you can see the typical raised rubbery border that's classic for syphilis. Whereas at other times it can still look just very much like herpes. So again, I would say if you're diagnosing and treating somebody for herpes, I would encourage you to test them for syphilis and consider empirically treating them for syphilis as well. The secondary syphilis rash, again, can be just a very diffuse macular rash. And I'd like to explain to folks that the rash actually looks like it's coming up from underneath this the surface, like it looks like it's coming up. And that's really a classic presentation, which may or may not involve the palms and soles. If it does involve the palms and soles, here's an example of how it can almost look more scar-like in nature, and the feet can look like that as well. These are examples of mucus patches. Here's patchy alopecia. And then condyloma lata. The thing to recognize about condyloma lata is it can be confused with condyloma that is from HPV. And really the difference between the two, when I think of HPV condyloma, that tends to be very verrucousy and sort of cauliflower-like in appearance. Whereas condyloma lata, although it's raised and somewhat pedunculated, it's very flat on top. And so if you're not sure, if it has an appearance of looking more flat on top, that is more likely condyloma lata, more likely secondary syphilis. I would test and empirically treat that individual for syphilis. So all five of these are secondary syphilis and then primary syphilis here. So then if you're over here, an individual has these symptoms or has none of these symptoms, then you move to this treatment box. And if they have primary or secondary syphilis, they're historically treated with a single dose, and I know you all know this, of benzathine penicillin G. Currently, we are still in a international shortage of benzathine penicillin G, but the FDA has brought in extanceline, which is the equivalent drug of benzathine penicillin G. So you could replace the benzathine penicillin G with extanceline, or you can simply treat the individual if they're not pregnant with doxycycline 100 milligrams PO BID times 14 days. In most cases, primary and secondary syphilis is occurring in an individual who has been infected for less than a year. If individuals have no symptoms and you confirm they've been infected for more than a year, and sometimes you don't know, so if you don't know, then you want to assume that it's been more than a year, then that individual needs 3 doses IM times 3, or doxycycline for 28 days. That's really kind of the summary of the syphilis algorithm. I think the most important thing is make sure that you're asking every single patient about otic, ocular, and neurologic symptoms because they are subtle and patients often do not complain of them unless you ask. Okay. Any questions before I close this algorithm out? Okay. No questions. Then I'm going to stop sharing, go back to the slides for just a moment. Okay, so now we're going to move up. I see one question. If a patient self-reports that they have been treated, should we retreat? I'm glad you asked the question because that is why the first thing we ask you to do is go through the symptoms. So the first thing you want to do, even if somebody tells you they've been treated before, is go back through and walk through all of those symptoms and ask them any decreased hearing, any, red eye, pink eye, any dizziness or lightheadedness, You just walk your way through the symptoms before you make a decision as whether to treat or not treat. And then if there's no symptoms and you are able to confirm that they've had treatment, and they have no recent exposure, that's the other thing. You need to make sure that they've had no exposure since they had that treatment. Then it's okay not to treat. But if there's any exposure since their last treatment, if there's any symptoms, then you want to go ahead and treat. Okay, next slide. So I'm going to just take a moment and talk about some of the data that was established around rapid treatment for HIV. So this data came from San Francisco General Hospital, and what they did back in 2015 is they looked at the difference between rapid same-day treatment versus universal antiretroviral therapy, which at the time, what that meant was that somebody was, when somebody was diagnosed, they were referred to an HIV clinic. They had an intake appointment at that clinic with the insurance folks, got their baseline labs, and then saw the provider 1 to 2 weeks later. And at the point that they saw the provider is when they would begin antiretroviral therapy. And they compared that to starting patients on the same day that they got their diagnosis on antiretroviral therapy. And what they showed is that you can decrease the time to undetectable viral load on average by 1.8 months if you begin somebody immediately on antiretroviral therapy. So this was one of the first studies that looked at rapid treatment. Next slide. And then this study was done by Harvard in Haiti. And this study looked at same-day versus 21-day delayed HIV treatment. And what they did with the 21-day delayed treatment is that the day of diagnosis, they would, on that first day, they'd give them some adherence counseling. Then they'd have them come back in a week and they'd give them additional adherence counseling, reinforcing why it was so important that they adhere to their drugs for treatment for HIV. And then on the third visit, so each of those visits were a week apart. On the third visit, they began them on antiretroviral therapy. And they compared that to beginning somebody on antiretroviral therapy the very same day that they got their diagnosis. And then they looked a year later and found that for those patients that began same-day treatment, that more patients were alive, virally suppressed, and retained in care than those that had that weekly adherence times 3 weeks before they began treatment. And these are the two studies that really led to recommendations to begin rapid antiretroviral therapy treatment on the day of diagnosis, as opposed to waiting until you refer somebody to clinic. And now US national guidelines, as well as really international guidelines, recommend same-day antiretroviral therapy for somebody who's diagnosed with HIV. Okay, now I'll switch back over to the HIV screening algorithm. And wait 1 moment. Realize I need to do one thing to do that. Okay. Can everybody see this okay?
Yes.
Yeah, okay, great. So again, we're going to start with, you have a positive HIV screening test. So in most emergency departments, I think that positive HIV screening test is most likely going to be the antigen antibody test, which really is it actually does tell you that somebody's positive because they're either antigen positive or they're antibody positive, or they're both antigen and antibody positive. The confirmation tests that you run for HIV are really to tell you, is this individual chronically infected, meaning they've been infected for 4 weeks or more, or are they acutely infected, meaning they've been infected for less than probably 3 weeks. And so if they're antibody positive, on confirmation, they've been infected for a month or more. If they're viral load positive but antibody negative, then they're acutely infected. So so when you get that initial antigen antibody test positive, or if you're doing a rapid test, you're likely to just get an antibody positive. Although Abbott now makes a antigen antibody rapid test as well. But whichever test you get, that initial positive screening test puts you in a position to be able to begin antiretroviral therapy while you await to confirm whether they're acutely infected or chronically infected with the second and third tests. And so what this algorithm is doing is really to walk you through on which of these individuals with an initial positive screening test can I begin rapid ART, and who do I need to wait until I rule out one of 3 key opportunistic infections that put individuals at risk for a disease called IRIS, or immune reconstitution syndrome. And those 3 diseases that we're trying to rule out are cryptococcus, tuberculosis, or MAC. So this algorithm is really meant to kind of walk you through really how to go about that. And one of the first things to recognize about patients who have end-stage AIDS who are presenting with one of these 3 to opportunistic infections, but really with any opportunistic infection, is that they typically have been sick for a few months before they often present for care. Because opportunistic infections, the way to think about them is they're very slow growing, progressive infections that take a while to really, typically bother a patient enough that they're going to come in and seek care. And so often by the time they are seeking care, they've been sick for a long period of time. And so so when they come in, if they have any of these opportunistic infections, they've probably been sick for anywhere from 1 to 2 months before they're presenting. So recognizing that, when we're talking about vital signs associated with these individuals and whether or not they might have one of these opportunistic infections, we're looking at reasons in this first box for why an individual needs to be admitted and needs to be ruled out for Cryptococcus TB or MAC before you can start antiretroviral therapy. That is the whole purpose of this algorithm. It's not meant to be a comprehensive algorithm to tell you when or how to do a workup for sepsis or anything like that. That is not the purpose of this. It's really, can I start antiretroviral therapy on this person who just screened positive, or do I need to hold and rule out for crypto TB or MAC? And so these critically abnormal vital signs, if an individual presents with any one of these vital signs, even though your work in the emergency department is going to be to stabilize those vital signs, even if you get them stabilized in the emergency department, those individuals need to be admitted to the hospital if they're HIV positive, because those individuals likely have an opportunistic infection that's been progressing over time over the last couple of months. And these are the individuals who, if not admitted and worked up and appropriately treated, can crash very quickly. So they kind of hover, and then they suddenly come crashing down. But that hovering can go on for months. But when they hit these critical vitals, that individual is crashing and they need to be admitted because that opportunistic infection has been progressing probably for months at that point. So that's the purpose of these particular vitals. And any one of these, even if you turn it around in the emergency department, that individual needs to be admitted and antiretroviral therapy held. Now let's talk through the other symptoms that would make you want to admit that patient and at least temporarily hold antiretroviral therapy. So a new onset seizure in a HIV positive individual is almost always cryptococcus meningitis. Now, sure, they could have cysticercosis, they may have lymphoma, but more often than not, it turns out to be cryptococcus meningitis. So that should be an alert for you. A patient with a progressive headache. And so, I'm not worried about that patient who's had headaches, on and off for the last few years. I'm worried about a patient who tells me that they have a headache and that headache has progressed gradually over the last few weeks or the last month or two, and that's new for that individual. And that often, but not always, is cryptococcus. It can also be neurosyphilis, could also be lymphoma, and can sometimes be toxo as well. The other thing is cognitive delay or altered mental status. And I specifically called out cognitive delay because one of the very subtle findings of cryptococcus is this very subtle cognitive delay. You'll ask them a question and it just seems like they're delayed in responding to you. They're not altered, they can respond, they tell you what's going on, but it just seems like it takes them just a little bit longer than it would take the average person to respond. And that is also very classic of cryptococcus meningitis. So if you have cognitive delay, that would also be another reason why that individual needs to be admitted and needs a CNS workup for cryptococcus meningitis. And of course, altered mental status, clearly you would be admitting that individual anyway, but it's really these subtle symptoms that you want to pick up on, because these are the reasons patients often get sent home repeatedly, because they're so subtle that unless you know to look for them, you'll miss them. Again, decreased hearing, that's just to bring up neurosyphilis again, to make sure that you're aware of that, but also it is possible to happen with cryptococcus as well, but it's not a common finding there. Double or blurry vision, and I would say double vision probably more commonly here, because individuals with double vision often can either have cryptococcus and they're having increasing intracranial pressure as the cryptococcus is multiplying in the CSF fluid, and the pressure increases, and so it puts some pressure on the cranial nerves, which results in double vision for the individuals. Blurry vision, because that can be a part of that, or patients sometimes can't distinguish between the two, but again, because you're also thinking about neurosyphilis here as one of the possible opportunistic infections that individuals with HIV may get, but ultimately that won't prevent you from starting antiretroviral therapy. But also, blurry vision sometimes is the way individuals with CMV, cytomegalovirus, will present or complain about their vision, which would be also a tip-off to you that they have an opportunistic infection, but it's not one that you have to hold antiretroviral therapy for. Then any weakness in extremities, which would, I think be obvious to all of you that that individual is going to need to be admitted. But then also very subtle ataxia. Notice I mentioned that in neurosyphilis. I'm going to mention it again here. This ataxia, unless you get that person up and walk them, a lot of times you are not going to recognize it. So you want to put them through the classic cerebellar exam findings, and also just get them up and walk them and see if there's anything abnormal there. That's a high suspicion for Cryptococcus meningitis. The weakness of extremities, I would think more of toxo there and less of Cryptococcus. So any of those individuals, so if a patient has yes to anything in this box, that individual needs to be admitted. And then based on whether it's neurologic, respiratory, or maybe it's you can't identify either, but they have an abnormal vital, all of those individuals need to be admitted and worked up. Now we'll talk through respiratory for a minute, and then I'll go down and walk you through the workups that are recommended for these individuals. So respiratory, when you're talking about an opportunistic infection, either TB or PCP, rarely, again, do patients present initially when those symptoms happen. Typically, they've been going on for longer than a few days. And so I'll just say, as an HIV provider for 30 years, the 1 week cutoff is always very helpful. If those symptoms have been going on, fevers, chills, night sweats for more than a week, TB rises in my differential. If cough or shortness of breath has been going on for more than a week, then I'm thinking either PCP or TB in an individual. There's been a rare patient who came in with symptoms less than a week that turned out to have PCP, but more often than not, it's been going on for more than a week when they come in. As well, weight loss in the last month, because that can be a tip-off to both TB, PCP, and also MAC. And fever, chills, and night sweats is also one that's pretty common presenter for MAC in an HIV patient. So yes to any one of these symptoms, an individual with an initial screening test positive for HIV, that individual needs to be admitted and antiretroviral therapy temporarily held. So we'll walk through what the workup should be for these individuals, and then when you could then move towards starting treatment. So let's go down to the more straightforward ones, which are if that individual had any of the neuro symptoms, then what you're looking for is Cryptococcus, neurosyphilis, toxoplasmosis, or lymphoma. Those are the sort of heavy hitters when it comes to CNS presentations in an HIV patient. The only one that you actually have to hold the antiretroviral therapy for is Cryptococcus, because that's the one that's at risk for IRIS if you start antiretroviral therapy before starting treatment for the Cryptococcus. But you work up for all of them because all really these three, Cryptococcus, neurosyphilis, and toxo, are by far the most common, with lymphoma being up there, but just not quite as common as these three. So you want to send a serum for cryptococcal antigen or serum CRAG. Plus, if you haven't already done so, and you may have if this patient's getting screened for all three, both a TPA for syphilis and an RPR for syphilis. Just send them both right off the top. You want to do a CT of the head with and without contrast, because that's going to tell you if the patient has toxoplasmosis or lymphoma. And very rarely an individual with Cryptococcus can get what's called a cryptococcoma, which you can identify on a CT. And then you want to do a lumbar puncture. And I included here, because I know these are not historically commonly done in the emergency department, but are critical for managing a patient with Cryptococcus, is getting that opening pressure. So if you have an HIV patient who you're doing a lumbar puncture, grab an opening pressure, which I know takes a little extra time, but is really critical because it's that opening pressure that's used in the future management of that patient to determine whether or not you may need to do further lumbar punctures to release some of the opening pressure, some of this pressure, the intracranial pressure. And then, of course, typical cell count protein glucose, but then a CSF for cryptococcal antigen, include a VDRL, and include a fungal culture, because all the serum cryptococcal antigen, the CSF cryptococcal antigen, and the fungal culture, all three of those are needed in the management of a patient with cryptococcal meningitis. So for these patients, you send all of these tests, and if your serum Craig is negative, the likelihood that your patient has cryptococcal meningitis is pretty likely to be nil to nothing. But you can also send a CSF Craig if you have or if you send a CSF Craig, you need to wait for that CSF Craig. But if you get a serum Craig that's negative, the chance that you're going to have a CSF Craig that's positive is pretty low. So once you've ruled out that that individual has cryptococcal meningitis, even if they turn out to have toxoplasmosis, lymphoma, or neurosyphilis, you are okay to move forward with going towards beginning antiretroviral therapy. So coming over here, making sure you have the appropriate labs, and we'll talk through this piece, but then you're able to move forward with beginning antiretroviral therapy. I know that's a pretty loaded one. I'll just stop and check and see if there's any questions. Okay. If no questions, then I'll move down to the respiratory. And again, remember, for respiratory, these are the individuals that had fevers, chills, or night sweats for greater than a week. They had cough or shortness of breath for greater than a week. And they may or may not have had weight loss in the last month. So again, they just have to say yes to any one of those. And you would move into a respiratory workup. So those individuals need to go into airborne precautions. They need a chest x-ray if they don't already have one. They need induced sputum for PCP, direct fluorescent antibody. They need induced sputum for TB, and at least one of those, but more is one of those sputums should be a gene expert. But if you can get 2 or 3 gene expert, you know, of course, that's just an added benefit, but at least one of them needs to be a gene expert. Typically, this rule out is going to often take 24 hours or more. But once you've determined that you've ruled this individual out for TB, so TB is ruled out, then you can again move towards this ordering and movement towards treatment. So often individuals who you're ruling out for TB, those individuals will more likely be started up on the inpatient service as opposed to in your emergency room, unless for some reason you're housing your admissions, then those individuals might still be in the ED by the time their TB is ruled out. But you have to rule out TB before starting ARTM, respiratory symptoms. Then we'll come up to the final one, which for the most part reiterates what we just said, but it's just important to know that if all you have is abnormal vital signs, any one of these, you can't really identify a true respiratory or neurologic cause, then those individuals get both the neurologic and the respiratory workup to try to find an etiology, because there's, again, a high chance that they have an opportunistic infection, and that opportunistic infection has been going on for a period of time, and that's why they've now, you know, hit these critically high and abnormal vital signs. So you really have to sort of do a more comprehensive workup to look for neurologic causes, you're again looking for the same things: Cryptococcus neurosyphilis, toxo, and lymphoma. A respiratory workup looking for PCP and TB. And once you've ruled out Cryptococcus with your neuro workup, and you've ruled out TB with your respiratory workup, then the only other thing you have to think about is if both of those workups were negative, your neuro workup was negative, your respiratory workup was negative, but your individual had abnormal vital signs, then you have to think about, does this individual actually have MAC, Mycobacterium avium intracellulare, also called MAC. So those individuals, they often, the clinical presentation can just be fever, but as it progresses, fever, chills, night sweats, weight loss, and then it has a propensity for really 3 areas. It goes after the lymph nodes, it goes after the bone marrow, and it goes after the biliary tree. And so individuals with MAC will often have an isolated low hemoglobin or a low red cell count, which then progresses to a low platelet count. So that's where it hits the bone marrow. So initially at the red cell count and then later at the platelet count. So those tend to go down. So if you have an isolated anemia, my suspicions in a patient with fever, chills, night sweats, and weight loss in an isolated anemia, my suspicion for MAC goes way up. If they have anemia and neutropenia, my suspicion for MAC is high, but sometimes can be harder to delineate those individuals. And ultimately it can hit all lines, but it often is red count, platelets, and white cell count, sort of in that order. Then the other place that MAC hits is that individuals will get lymphadenopathy, and sometimes that's in the perineum, or not the perineum, I'm sorry, the mediastinum. Sorry. It's in the mediastinum. And sometimes it can be in the abdomen. And then the last place that MAC hits is in the biliary tree. So these individuals often have an isolated elevation of ALK phos and bilirubin with not much impact on the AST or ALT. And so those individuals are really anyone with vital signs that have a negative neuro and respiratory workup, but have these critically abnormal vital signs. You want to send blood culture times 2 for AFB to rule out MAC. So after having kind of walked through this red area here, all of these individuals are getting admitted. Once you've ruled out crypto, once you've ruled out TB, and here you've ruled out crypto, TB, or MAC, those individuals, once they're ruled out for those 3 diseases, can now have blood work ordered, a complete metabolic panel, an HIV viral load, an HIV genotype, a CD4 count, a urinalysis, and then if they're female, a pregnancy test. For individuals who have a GFR less than 40 on their chemistry panel, AST and ALT more than 5 times the upper limit of normal, or they're pregnant, or they've had previous antiretroviral therapy, you would want to consult your ID or HIV specialist before beginning antiretroviral therapy on these folks. If, on the other hand, their GFR is over 40, their AST and ALT are less than 5 times the upper limit of normal, then you can go ahead and move forward with treatment. And the recommended treatment for rapid ART is to use what we call integrase inhibitors. And Biktarvy is a single pill that includes Bictegravir, which is an integrase inhibitor, plus emtricitabine and tenofovir alafenamide. So it's a single pill with 3 pills. Or you can use dolutegravir, plus Descovy. And dolutegravir is an integrase inhibitor. And Descovy is the same other part, the emtricitabine plus tenofovir L-efinamide. So with Biktarvy, it's a single pill. With dolutegravir, it's 2 pills, but in both cases, it's once a day. And we recommend that you discharge them with a 30-day prescription so that they don't run out of medications before they get officially hooked up to treatment. And just one last thing, which is if you go through all of these symptoms with an individual and they have none of them, then you can also move towards starting antiretroviral therapy. And you follow the same path over here for starting antiretroviral therapy. So again, this is a pretty loaded algorithm. Curious if there's any questions about this. Folks seem quiet. I'm hoping that we have some of the clinical providers on the call, since a lot of this is the clinical workup that you all want to be comfortable with. Okay. If no questions, then I'll stop sharing this and switch back to the slides for a moment. Okay, next slide. And I see we are down to about 8 minutes, I think. So we wanted to talk about empiric treatment and really treatment outcomes in individuals who had rapid treatment with hepatitis C versus sort of standard of care. So this particular study looked at a syringe service program in New York City, so just out in the field, where they looked at 18 to 29-year-olds who were RNA positive, so HCV RNA positive, no previous history of treatment, and they had injection drug use in the past. So they had 25 participants that they randomized 1-to-1 to rapid treatment or usual care. And the rapid treatment arm received same-day medical evaluation, baseline lab testing, and a 7-day starter pack of sofosbuvir and velpatasvir. And what they found, if you look over here on the right, is that that 64% in the rapid treatment arm achieved sustainable viral repression. I'm using the wrong term there. Sustained viral response. There we go. They had 64% in the rapid treatment versus 9% in the standard of care arm. And so they found significantly higher rates of sustained viral response using the rapid treatment. We'll just make sure you know that these particular individuals, they were HCV RNA positive. Next slide. And then this is the NOW study, which was done in San Francisco in non-medical sites that focused on people experiencing homelessness and injection drugs. Again, these individuals were HCV RNA positive, over 18 years of age, and they reported either injection drug use in their lifetime or having a blood transfusion before 1992. There were 89 participants that were offered HCV treatment at point of diagnosis. 2 of them declined and were just referred to local care. So 87 enrolled participants received same-day baseline labs and 2-week sofosbuvir and velpatasvir starter packs. And they found that in 67% in the intention to treat group and 84% in the protocol group had sustained viral response or suppression at 12 weeks. And treatment at the point of diagnosis, they determined, reduces the likelihood of loss to follow-up. Hence why we are talking with all of you about thinking about beginning treatment in the emergency room. So now I will try to share my screen. Need to switch screens here for a moment. Okay. Can you all see okay?
Yes.
Okay, great. And I see we have 4 minutes, so I will try to do this fairly quickly. Probably will go over by 5 minutes, but so this is currently most folks are going to do an HCV antibody test. So they're going to have a reactive or positive HCV antibody test. I will let you know that there is a rapid viral load test out there that right now is being evaluated. So it may be that you will soon have available to you a rapid viral load test that you could then test these individuals for viral load as well. But assuming you don't, you really have 2 choices. You can do an assessment with your HCV antibody test positivity and decide to treat empirically on that. That would be newer, that would be cutting edge. That's not something that is standardly done right now. But I will tell you that when we started rapid HIV treatment back in 2014, that was not something that was standardly done on initial lab results. And now it's part of the HIV treatment guidelines. So things progress over time, and I think emergency rooms often play a critical role in really advancing science because of the need to think more progressively so that patients don't fall through the cracks from emergency rooms. So it's really up to you if you want to do this based on antibody test positive, or you want to wait until your patient's viral load comes back and test based on the viral load. You know, do that treatment, maybe give them treatment and tell them only start it or only pick up the prescription if they test positive, you know, and you call them and tell them they have a positive viral load. Really up to you how you want to approach this, because we are kind of moving towards a little bit of a cutting edge model here. But based on a antibody positive, the first thing you want to do is ask the patient, have they been treated for Hep C before? If the answer is yes, then you need to refer that individual to the Hep C specialist. Meanwhile, you can get their Hep C viral load because maybe they were treated and they have sustained viral suppression even now. So you want to check what that viral load is. And you can share that viral load with the Hep C specialist, or, you know, if they've been effectively treated, they don't necessarily need to go back to the Hep C specialist. If they've not been treated before, then you want to order these labs. CBC, we put complete metabolic panel here. You have to make sure that whatever metabolic panel you do, you have a creatinine, you have an eGFR, an AST, ALT, albumin, total and direct bilirubin. So whatever combination of metabolic panel and liver function test get you, that is fine. A PT and INR and PTT and HCV quantitative viral load. And then you want to rule this individual out for hepatitis B, although you do not have to hold treatment for the Hep B test, but the providers that are going to manage this patient are going to need to know the Hep B status of that individual, as well as HIV if you haven't already done HIV, and then a pregnancy screen if they're female. If these labs are all normal, then you just need to look for either liver disease or special considerations. If those are all negative, then you can move towards treatment. If it's yes to any of these, so you have exam findings of liver disease, jaundice, ascites, pulmonary edema, spider angioma, gynecomastia, etc. You all know these. But if they have exam findings of chronic liver disease, if they have a prior CT or ultrasound findings of cirrhosis or fibrosis, excuse me, they have presence of known other liver diseases like hematochromatosis, etc., alcoholic liver disease, hepatitis B, etc. If it's a yes to any of those, you need to refer them to the HCV specialist. Or if they have any of these special considerations, they're pregnant or breastfeeding, they have uncontrolled comorbidities, they're less than 18, they have a history of liver transplant, they have known or suspected hepatocellular carcinoma, or a life expectancy for less than 12 months. If yes to anything in this blue box, then these individuals get referred to the Hep C specialist. Or if they have abnormal labs, and the critical abnormal lab here is a platelet count less than 150. The liver experts say that a platelet count less than 150 is one of the simplest tests to determine whether or not somebody has a healthy liver or they have cirrhosis. Now, we all recognize that there could be other causes of platelet counts less than 150, but in the case of someone who you're thinking about treating for hepatitis C, you want to make sure that someone who does have a platelet count less than 150, you refer them to the HCV specialist. Or if they're co-infected with HIV or hepatitis B, they have a low GFR, or they're pregnant, all of those individuals should be managed by an HCV specialist, and I would not begin treatment in the emergency room for them if they meet any of these special considerations we talked about, or they have P450 drug interactions. So for individuals that you're moving towards treatment, the next step is always to look to see if they have P450 drug interactions. So if they do, those also need to be managed by an HCV specialist. So this box is really to say you want to hold the antiretroviral therapy treatment for Hep C and refer them to the Hep C specialist. Ultimately, many of these folks will probably be treated by the Hep C specialist, but they just need much closer monitoring before treatment begins and during treatment. For those individuals who have normal labs, have a platelet count less than 150, do not have any findings of liver disease or any special considerations, and do not have any P450 drug-drug interactions, then you can move towards treatment. And again, we recommend that you give a 30-day supply of treatment, and you can either use Mavorette, which is 3 tablets taken daily, taken with food, and you complete an 8-week course. Or Epclusa, which is 1 tablet daily, which can be taken with or without food, and the course is 12 weeks instead of 8 weeks. And again, start them on a 30-day starter pack, and then refer them for to be linked to care for follow-up. And I know it's 10:04, so I will stop there. And we can also just bring these back up at the community of practice tomorrow and answer any additional questions or any questions that anybody has. I will stop sharing. It's a quieter crowd today.
Dr. Jacobson, I wasn't sure before I wrap up if you wanted to comment on the one last comment in the chat or address that tomorrow.
Just curious if, I'll address it. Just curious if on the opportunistic infection workflow to determine or rule out opportunistic, can any of those occur without the vital signs being out of the norm? Yes, so the purpose, I'm glad you asked that question. The purpose of that initial box is you only have to say yes to any one of those. It could be an abnormal vital sign. It could be a neurologic sign. It could be a respiratory sign. So it's yes to any one of those. Then that sends you down the path to do the workup. So you don't have to have abnormal vitals plus that. You have to have maybe just one abnormal vital, and then you need to do the workup, or you have just one respiratory complaint and you need to do the workup. So it's there, each of those symptoms in that top box for opportunistic infections, any one of those in isolation sends you down the workup path. Great question.
Wonderful. Well, we will end there, I think, and I'll go ahead and just wrap up. We're sharing some resources in the chat, which we will share, of course, in our recap email, which include an updated SOP, which now includes point of care testing. Also really exciting is that there's a new FAQ section on the Data Hub for your data questions. And your next steps are to meet as a team to discuss these protocols and processes and to develop them for your team, draft up SOPs for test to treat and empiric treatment. Remember to register for next month's webinar, where it's really exciting. We're going to have a panel of patient navigators, which you all have been asking for. And then, as we've said, community of practice is tomorrow, which is exciting timing to incorporate all of this clinical information and bring your questions. And then, of course, remember, we always really welcome your feedback. It helps us to hear what your experience is so we can support you. We integrate that into future webinars, and that survey does include a clinical question directly from Dr. Jacobson that we are asking for your support on. And you know how to reach us on our website or email. Thank you all so much. A lot of appreciation, Dr. Jacobson, in the chat for how informative and helpful today was. So thanks everyone for your attendance.
Yeah, and just to add that question at the end, you can go ahead and put up the survey questions, but the question at the end is really, we're trying to get buy-in, hopefully from emergency department providers, since they'll be the ones that are implementing this, as to which emergency department screening recommendation for pregnant women would be easiest for them to implement. We're looking for ease. So if you can give your opinion.
Wonderful.
Thank you, everyone.
All. Thanks, Dr. Jacobson. Take care, all. We'll see you tomorrow morning.